Now I hit record.
Okay.
So now we're recording like real people. All right, great. There we go. So we can talk a little bit about, I am a pelvic physical therapist. I am the co-founder of the Endometriosis Summit. Dr. Vidali is my other partner in crime. He was busy this evening in the OR. I also have endometriosis, and I've been through it all, from being single with endometriosis and having to experience that aspect of sex, to not understanding that sex isn't supposed to hurt, to having to go through the fertility battle. And then, of course, for me, having to go, the worst part was what it does and the repetitive surgeries does to your body. So I did love that you included that in the blog that you wrote. But Niva, why don't you tell us a little bit about what you experience as a PT who is able to listen and give space to those with endometriosis and this particular topic?
Yeah, I mean, really, I like to have the patient, whether they come in the first time on their own, or if they bring in a family member or even a partner or anybody they have, just to really hear that entire story. Let them come in, sit down, and start from wherever they feel comfortable in their history, share their experiences. Most of them have been to several medical and health professionals, whether it's other pelvic PTs or general PT, surgeons. I mean, you know, the gamut. Some have moved from state to state, sometimes following a healthcare professional, and sometimes they're there just because they've had to move because of jobs and medical help. And I do tell them, you know, especially when some of them are just a little bit quieter, they're not sure what they're supposed to share. I really tell them that that is their time and how much I learn from their experiences. And I think once they hear that I'm learning from what they tell me, they are able to open up even more.
Right. So I think we talked about, so the pelvic guru, Tracy Scher, is going to join you on this panel. And she had a very interesting post. I believe her Instagram is Pelvic Guru 1, which very much fits with our theme of change the narrative, which Susan Clinton is going to run for us, but in that words matter. So many of us, it's funny, if we had a show of hands, which we will do at our event, the first thing that many people experience when they have painful sex. And for me, I walked up the hill in college right to the student health center knowing it probably wasn't supposed to hurt. And the first thing I was told was, well, why don't you try some wine before sex?
Right.
And
Relax.
so, right. And those are words that now we have a bunch of women in pain who are self-medicating with wine because the student health center gynecologist tells them that that's an acceptable thing. So when we talk about words matter, I think that physical therapists really have an opportunity to say to the person with endometriosis, like, let's explore the options that'll attend to your symptoms. Not let's minimize it by giving you some stupid thing. Let's say just relax, but on saying, you know, I'm going to really hear you. And so that's one of the things that you were saying was that you give them that space.
Yeah, no, absolutely. And, you know, it does sadden me to some degree. Like I said, I've been doing this since 2004. And back then I thought it was an interesting comment for them to be getting. And it still exists now in just about 2020. I still hear that. Or, you know, their friends even tell them like, oh, honey, just relax, you know, it'll be better after the first time or that first experience, or it'll just get better and, you know, have another glass of wine. And it's, you know, we're not really getting to that root cause with the glass of wine.
Right. Or we get a lot now of, and I love CBD products for painful sex and for pain in general. But now I get the youngins coming in, well, I tried a CBD suppository and it didn't help.
Right.
So, you know, we want you as people with endometriosis to understand that sex shouldn't hurt. So Niva can talk a little bit about, I wanted to talk about, basically there are two categories of painful sex. You'll be very good at this. So we have some diagrams from the Pelvic Guru, but they may or may not come up. So the first one you're going to see is if you have pain see, it has that glare from the iPad screen. But I've done this on Endo Education Live, so you can see a little bit that there is a superficial layer to the pelvis. How many people do you think come to you and don't realize the whole pelvis is muscle?
Well, I mean, I don't think they even understand what it is and where it is and why that's hurting them. It's definitely, you know, an out of sight, out of mind. Like they're not physically seeing what works there. So, and then once you tell, they're like, wait, but how many muscles are there? You know,
Right.
Nerves, forget the blood supply, forget the organs. They're like, wait, I have all of that. And it's nice to show them in those different layers,
Right.
you know, how things can work layer to layer.
So that concept of, oh my God, all of that is in there is why, even though these pictures show up a little funny because of the screen I have on my iPad, this is why we've chosen to show you these tonight. This is the deeper layer of the pelvic floor. And I understand that there is glare, but we're going to talk a little bit more about these. And again, Pelvic Guru does have the photos available. So those are the muscles involved. The other thing I want to show you, we'll see if it comes out, is these are the organs that are involved. And you can see almost in the center, there's a little bit of a circle and everything right at the end of the vagina. And so when you have endometriosis, typically you have endometriosis is what's called the cul-de-sac or the rectovaginal septum. I'm sure you've seen that on patients, right?
Yes, 100%.
Yeah, and so when you see that on patients, if you choose to have penetrative sex, you're going to bang right against nodules of endometriosis. And what might that feel like for a patient?
I mean, they come up with different words to explain it. A lot just say they cannot tolerate, or they're really just, you know, biting through their lips, or they feel like they're banging into a wall that's super painful.
Right.
Or a deep ache, but most are unable to tolerate, and understandably, it is definitely a sensitive area.
Yeah, so we typically with endometriosis think about painful sex as being either from the muscles, which was the first set of pictures that I showed you, or from endometriosis in the rectovaginal septum, or on a ligament called the uterosacral ligament. The uterosacral ligament is the first place typically that endometriosis begins to deepen. So whether it's superficial or deeply invasive disease, you're always going to have endometriosis a lot of times on the uterosacral ligaments. Unfortunately, if endometriosis is on the uterosacral ligaments, you're going to get a lot of back pain. So Niva, how could having back pain affect somebody's sexual pain?
So one, if you just think about outside of those pelvic floor muscles, it's connected to a full body, right? And so the different positions are bothering them. They don't know what position to actually get comfortable in. Some of it is just referred pain, so it's coming from that deep area, but yet referring into their back. And they're not finding where to place themselves and where to place their partner. And they just can't go on from that, basically. What's nice is that once they learn to use their body, they may be able to find something that is less painful, manageable, and can become sexually active. So there's definitely hope in the future.
Right. So this part is so fun because I'm on vacation. My parents are literally like down the hallway.
Oh, no, I don't know what my kids are thinking yet.
Right.
They've heard the big sex word.
Right. But I think they have to get used to it. So this is what I'll say is when you have deeply invasive endometriosis or DIE, and you have that rectovaginal cul-de-sac endometriosis, anything that provides deeper penetration is going to be painful. And so you want to look for positions that are shallower And that also because sex itself, and we had a whole Facebook Live on trauma from Casey Berna, but because of the trauma that's involved in repeatedly stabbing, basically like something that's as painful as appendicitis every time somebody thrusts. It's so great. I'm so happy my parents are in the next room. So you also want to choose positions in which the woman is in control, or
Yes.
the person, rather, let's put it this way, the person with endometriosis, because we know everybody has endometriosis, depending on how they identify, that person has some level of control. So,
Right.
you know, I have learned actually through a lot of the GFAM webinars, because we have GFAMers coming to our summit, even if that means a safe word, because sometimes, right, it's not just about the one person being on top. Sometimes it's about the control level is a safe word. And sometimes it's about understanding what positions are going to be shallower.
That's why I also like them to explore different positions on their own without any penetration, because like you were saying, the back pain. So what if laying on your back already causes you back pain? You're not even introducing something that may lead to more pain. So we find different ways that they are first comfortable. I love using pillows and bolsters, and I'm sure we'll get into the whole O-nut, the world of the O-nut. There's definitely things out there these days, and props. I recommend, if they want, like, let's say the leg up is nice, but they're getting tired or they have hip pain, have your partner hold on to your leg. Use passive tools to get you. But I feel like the person with the endometriosis needs to know their body and what is comfortable first to them without introducing anything outside that would cause more.
Right. So it's great. We'll talk about some of the fun things that you mentioned. Niva mentioned the O-nut. O-nut is going to be at Endometriosis Summit. Last year, her name is Emily. She developed it herself. So we love a small businesswoman who had some ingenuity. And the O-nut is something that makes it so that it's almost like a stopper, so that you can still experience penetration, but that it doesn't go as deep, and it's adjustable. So there's 4 different rings. What is very exciting, we hope to reveal at the Endometriosis Summit a yellow O-nut, because of course endometriosis, the color of endometriosis awareness is yellow, and we are trying very hard. So if I fail, don't kill me. But we are trying very hard to get Emily to design yellow, because we kick off on March 1 and we want to sell that endometriosis. Why shouldn't you be aware in bed? Because your pelvis already is.
She definitely wins the best display.
Right. So the other thing that Niva mentioned, it's not like tacky or over the top to need pillows, to need bolsters. I've had patients tell me they have yoga mats and they roll them up, and they have yoga blocks and that's okay. And I think the most important thing is that we tell you that pleasure is a normal thing, and intimacy is also a normal thing, and however you get there, and that is also one of the first ways to start healing, is however you get there. Does it mean physical therapy? Does it mean surgery? Does it mean a pillow? And that's totally fine. Dr. Vidali always likes to, it's kind of a strange story, but all my teen patients that are having sex, he tries to explain to them, lubricant is okay. And there is some myth that if a woman's turned on, she must be really wet. And that is not necessarily true, because you could be really aroused and still need lubricant. A lot of our patients have had hysterectomies. A lot of them are on hormonal control. A lot of them are having surgeries, and everything changes, and so you shouldn't shy away from something like that. Also coming to the Endometriosis Summit with a table is Amanda Olson from Intimate Rose.
Nice.
Yeah, and she'll have products there. We think Babeland will also sponsor Yeah, so
Oh,
they
I
will
just
come.
was introduced to some of their products.
Yeah, they will come with a
Very
sexual
friendly.
educator, and we have somebody bringing CBD lube and a very high-end CBD product. So
Wow.
that may help as well. So
Yeah.
the other thing is when you think about the first set of photos that I showed, that was all pelvic floor. Why don't you greet our crowd and explain what are some symptoms, not from rectovaginal endometriosis, but if the pelvic floor is causing pain with sex?
Yeah, so those first set of muscles, I kind of call them the first line of defense, especially with anything with penetration, right? Because
Right.
some sort of restriction, now we're talking not necessarily from endometriosis being there, but just restriction in the musculoskeletal system, then the penetration is going to be a little bit more difficult. It could be anywhere from somebody sensing, wow, it's too much pressure or just too tight or not fitting, some people will say, to a muscle that has not been moved before and doesn't have the flexibility and kind of gliding ability. And as soon as something kind of hits it, let's say, or penetrates it, there's a very uncomfortable ache possibly, or a burn. And some people don't really understand that burn. When it's coming directly from the muscles, then I explained to them, if you had a really tight hamstring and you try to stretch and you pulled a little too much, you also sometimes get that burn sensation. And that's where, you have to back up and kind of figure out, okay, how do I prep that muscle for a little bit more flexibility? Can't talk as much range of motion, but there is some sort of range of motion to the muscles. We don't have numbers.
So the patients that say, I can't even get a tampon in, if you can't get a tampon in, it's very hard to get something else in there.
Yes.
And then, the other thing when we talk about words matter or changing the narrative, how many of our patients have been told, well, and this is my male doctors love to say this to women, well, there are other things you can do.
Yeah.
And yes, there are tons of other things you can do and tons
Sure.
of other things that are pleasurable, but it's a normal response that if you choose to have penetrative sex, that you should be able to have it. And plenty
Right.
of people, that's their end goal. And so
Right.
if those muscles are in spasm, like you're saying, it's very hard to get things in there. It's also very hard to get things out. So all our constipated people who may have not rectovaginal endometriosis, but bowel endometriosis, that may cause tremendous pain with sex.
Yeah.
So we have a couple questions, a lot of questions. We have a lot of people on. So I do want to say, we talked a lot about burning. I do a lot of work in female hernia, and that's a whole different webinar that we're going to actually have after the summit, because there will be, but when I hear burning, I really do fully evaluate the pelvic nerves and what's going on with the groin ligaments and with the groin itself. And that sexual pain doesn't always come from endometriosis or from pelvic floor. I know Dr. Shakande and Dr. Ahmed are going to come on and talk about vulvodynia. It could be a hernia, and then which I'm going to bring my next topic up after we talk about the questions. We're going to talk about bladder a little bit and sexual pain. But let's ask Niva some questions. So are there drugs that you like your patients to be on? We have a question about what about muscle relaxants? I know we're PTs, but do you must comment?
Sure. Okay. So the PT, we really, technically it's out of our scope to say, go get some muscle relaxants. But I have seen good results with, I'm presuming the person's thinking about Valium suppositories or the baclofen suppositories. They have helped many patients that I've seen along with the PT. I'm going to go back to listening and hearing the story of the patient. If that patient comes in and says, I'm not interested in anything medicine, I've done everything, I'm okay, it is definitely far from my my pushed to tell them, go get some Valium suppositories. I don't want to hear that, oh, but it'll make our PT better. That's not, we'll figure out a way to make the PT better, and we'll figure out a way to get your life better in different ways. But have I seen good results? Yes, for sure.
Yes.
Very little side effects.
Yeah. I know I have for the patients that burn, although the research does not demonstrate that it works, but we do use oftentimes a gabapentin cream.
Right.
But we try to use that as this is a gap measure until we can take you the rest of the way with PT. We should, we'll do a mention on surgery also, but let's ask them. So I have somebody else asking, what do you think of a yoni egg?
Oh, like a jade egg type of thing?
Right. What's your opinion there?
In regards to painful intercourse, I don't necessarily, they're not my favorite things, but I'm going to stay very politically correct. I don't do a lot of research on them. I have seen people overuse things like that, where if your muscles are already in that kind of guarded position, now you're holding an egg and walking around with one of these. So they're not really, I don't really recommend them or use them with my patients personally, but I don't know, do you recommend these?
I don't even use.
I'd like to be simple.
I don't like to use dilators that often with patients.
I know, yeah.
Because I feel that, first of all, it's like it goes to a very limited area. It's almost like if your calf hurt and you put a night splint on, and it's a low load prolonged stretch, so that if something hurts, the tool doesn't give. And then I personally believe that pelvic floor and working on that takes a whole body connection, and just shoving a dilator in or a wand in to like not one little spot, although it in your head feels good. I don't think it's actually getting to the signal from the brain and from the pelvis and the delicate dance our entire body does, including the diaphragm and the muscles, well enough. I'm not big with that. I know it's an issue. Definitely that will come up in probably our pelvic pain panel.
Yeah, I mean, I do use it. I use it a little bit differently as well. I at many times will use it as a tool to show the patient, especially if they're not sexually active, one, maybe by choice, or don't have a partner, don't know what it's going to be like. I really just use it as a tool to show them, or to have them see themselves what it feels like when something is coming near them, and it could be dangerous, and really how to learn that this might not be a dangerous and not fearful item.
Right. So I think that is to me, that is the appropriate use of a dilator or of a wand, is to say, hello, pelvis, let's have something happy associated with it. I think lots of patients use vibrators for that because there's already a positive association. The person with endometriosis has such a medicalized pelvis that to introduce them to something that's pleasurable so that they don't so that they are able to move on to penetrative sex is super important. That's an excellent use of that. I also sometimes have them buy they're very expensive, but the vulva puppet, which is a silk vulva. Right. And then they can see in a very non-threatening way. I wish I had one. You know, anyone that wants to donate one to me, because they're like $250.
Doesn't Tracy have one?
I'm sure she does. Maybe she'll bring it to her Pelvic Guru is going to have a table. But it's a very non-threatening way to look at everything. And then like you can put the dilator in the vulva puppet, and then you can put the dilator in you, and like it can be a positive experience, but I don't like them as a stretching, gnawing technique. So I do want to hop on and there is one question, and it talks about going to the same PT for 3 years and internal really hurts them, and should they keep going? And like, here's my thing. If PT isn't helping you, Niva and I are both extremely experienced with people with endometriosis. If PT isn't helping you and you're going and going and going, it's time for a new PT. It's not time to say, hey, I'll do, if you're not being helped, you have to look at the lens a different way. And my thought would be, if that particular PT isn't helping you, then they don't have probably enough experience to understand all of the causes of pain beyond pelvic floor that could be impacting you. So we had another question. We have so many questions. What about pain after hysterectomy, Niva? What do you, how do you approach that?
So that requires more than internal pelvic floor. I always look at the pelvis and a little bit orthopedically what the person looks after surgery, and more in a visceral approach in the abdomen 100%, and working on the restrictions that are left over from the actual surgery. So I'll start there before I assess their pelvic floor, unless they, again, are sexually active, already coming to me after the surgery and sexually active, and they're saying that there's still deep pain.
Right.
But
So
most of the patients haven't had something else addressed yet. They haven't even had PT when I see them like that.
Right. So the other thing, and Niva was my TA in the course that I took on it, but you know, the whole body is connected. And a lot of times in our patients who have had big surgeries, you need to look at the thoracic spine and
look up
breathing
high.
and the diaphragm. And sometimes you're spending 3 or 4 sessions just on that. And you haven't even touched the pelvis.
Yeah.
And I know I've been through 7 surgeries, and the last 2 were less than a year apart. And I couldn't turn one way or the other. So if the top of your spine isn't working right, then certainly the bottom of the spine isn't working right. And also, if we're talking about sex and relationships, you're not going to be able to do anything fun if your whole body isn't able to move.
Yeah, stiff and guarded, sure.
So for a lot of people who are asking out there, how do you know if it's a good PT? I think a PT that's able to address the whole body. You know, I once went to a pelvic PT for pubic bone pain, and she spent the whole time working on my foot. And you know what? My pubic bone felt great when I left.
Right.
So it has to be a pelvic PT that can address from head to toe.
Yeah.
Which a lot of people are also commenting that the good pelvic PTs don't take insurance, to which I say, I'm sorry, but I can't do what I need to do and be limited by an insurance company won't let me work on your foot.
And this could be a whole different webinar, but
yeah.
I will put a little soapbox in there. You often actually pay more, and so does your insurance company, for staying in insurance. You're going in 3-4 times a week, you're getting less one-on-one, but that's something else. I don't want to go
right.
Crazy articles lately about how much people are charging insurance companies.
So when we talk about pain from hysterectomy, I think it's a good time to just introduce this concept. We mentioned rectovaginal endometriosis, and if that's where your pain from sex is coming from, that you need to excise that disease at its root. You're not going to have a huge change in deep penetrative sex pain if you're leaving the disease behind, if you're burning it off the top, if you're even a hormone is not shrinking the disease that's in there. It's just putting a Band-Aid over the nodule that's being banged every time you want to have I did not do that on purpose. Every time you want to have penetrative sex. So we do suggest that people with painful sex do go through an excision. And then, you know, for all the reasons why excision has some insurance challenges, we do discuss that in the first panel at the Endometriosis Summit. But the crux of that is the standard of care set by the American College of Obstetrics and Gynecology. And so that also affects the pelvic PTs, because while they think pelvic PT is amazing for postpartum, they haven't come to the table and said the way it should be written is first you have excision and then you have pelvic PT. So that's just our little shtick there. For those that still have pain after hysterectomy, you know, you have to say, did I have a hysterectomy for adenomyosis, because then it would help my pain, or did you have it for endometriosis, because then likely the disease is still left behind. And we've talked about that a lot, and we'll talk about that more probably next week, but I do want to talk about that. So
And I was going to bring up also, that kind of brings back to the person who was asking about how do you know there's a good PT? I mean, there are many great good PTs out there. Sometimes not, they're coming into you with other things that haven't been addressed. Perhaps the surgery wasn't, you know, top of the line. I want to stay as politically correct as I can. Or there are other things. The nervous system is too wound up. And maybe the PT alone is not as experienced to bring that. There are other possibilities, you know, acupuncture may help, even maybe a gentle massage therapy, yoga therapy, things like that. So it's sometimes I tell people, sometimes it's not the right time. I don't like to, you know, tell them they've been to a bad PT per se. But also if you're doing the same thing for 3 years and it hasn't worked, you know, it's one thing you do the same thing for 3 years and it's worked, right? Or it's working. You're doing the same thing for 3 years and it's not working. Maybe it's time to ask, is there anything else you can offer me? And if not, okay, I'm gonna try something else.
I believe we're live in the Nook, but I'm not really sure. So I also, because I'm an admin there, I also would say that if you've been going to the same excisionist for say 5, 6, 7 years, and they keep reoperating and reoperating and reoperating, and they're supposed to be an excisionist. So yes, there are people who have excision-resistant endometriosis, but the numbers are low. You need to back up, widen the lens, and figure out what else could it be. Could it be a hernia? Could it be abdominal wall dysfunction? Could it be a diastasis, which Niva can tell us of what that is in a minute? Could it be bladder pain? Could it be the central nervous system? Could it be your SI joint? Could it be?
Yeah.
And so if you're not backing up and just going again and again and again and again to surgery, you should think about that. And I am somebody who has had needed a lot of excision, but who also has had multiple causes of pain that were very hard and very expensive to treat. And until you, including somebody once left a surgical artifact inside of me that rendered me infertile. So like, if you don't back up that lens and you keep going and doing the same thing, if the same thing isn't working, you have to change what you do.
Yeah.
And for some of you that may be voting with your feet to a new practitioner. Unfortunately, I had to have this conversation with somebody who called me this morning, and I get it that it's so hard because you've been through surgery. It's hard to do. It's hard to recover from. It's financially difficult. Then you go to PT. It's also a time suck because you're there. It's financially hard and it's physically difficult. And then you try to explain, well, just because, you know, you said I wanted excision doesn't mean the doctor actually did excision. And you have to really begin to delve deeper and to make sure you're what's front and center.
Yeah.
And I love that a good PT will teach you how to advocate for yourself. You know that, right, Niva?
Yeah, 100%.
So can you talk a little bit about what diastasis is? Because I would bet that from the repetitive surgeries, people see them. It's not just repetitive surgeries. It's fibroids in the uterus. If people have gone through and managed to get pregnant, you could have it. But it's a huge source of pain. And I think I gave a presentation earlier this year that it's often mistaken for adenomyosis pain because it's in that lower belly. Why don't you tell us a little bit about what that is?
You're referring to the rectus abdominis.
Right.
So, I mean, definition-wise, it means separation of those rectus abdominis muscles, which if you don't know what those muscles are, those are your six-pack muscles going straight down. But basically what we've seen over time, and so yes, the most common is pregnancy, you see a growing belly, but other reasons, one, and this happens often with endometriosis, GI issues, constipation, and straining, and that again, we're going back to that increased pressure in our body. So there's a stretch of the tissue in that midline called the linea alba, and now those muscles are being pulled apart. So some of you may see like a doming effect, or even a little valley going in. You may or may not see it along with a hernia in the belly button area. And overall there's a weakness in the abdomen, so that can go on to other issues. I know the research, we don't know definitely if it is a cause of back pain or not, but often, if there is weakness in the abdominal muscles, you may end up overusing a different muscle, let's say, like your back muscles or like your pelvic floor, and now you may end up in a pain syndrome.
Right. So I know that the research doesn't necessarily demonstrate it, but I had a huge diastasis, which I've never been pregnant. I do lift constantly because of my job, and like no one in all the PT I had ever had evaluated me for it, and it was pretty significant. And then I had on top of that a massive hernia, but that's a different story. But when it was fixed, like my back pain was so different, and my continence and my constipation were also super different. And so I'm somebody who had a lot of bowel endometriosis and who's done a lot of PT, and I don't have any fault because I wouldn't have checked it either. And now I check it on everyone, whether they've been pregnant or not, because I wish that I had done the prehab, because getting that stability, now not everybody needs theirs sewn shut. There's so much stability that can come to that from physical therapy. I mean, even the name of your practice, it like makes it so that you can have that stabilization to the abs. Yeah, it's so important. And the other thing is, it again gives you a sense of empowerment. And when you talk about sex and relationships, if you feel like crap and you feel like you're bloated and disgusting, right, it's not like you want to go running into bed.
No, and going along with that, people say, I don't feel like, I look myself, my belly doesn't look like it's like what it used to or what I want it to be. And that is something, if we can get those muscles to work more coordinated, more appropriately, more efficiently, then we can won't promise ever a flat belly to anybody, but we can get a better system going on.
Right. And I find with endobelly, with that, if your pelvic floor is in spasm at the same time, you're definitely going to bloat. And bloating is going to impact your relationship. Maybe you don't want to get dressed up and go for a date. Maybe your partner is so over Netflix and the couch, and I think there's lots of different ways that physical therapy can address like just how you feel in bed too. So the other thing is, we make a huge thing to try to be inclusive. And so it's not just heterosexual normative that gets endometriosis. Everybody gets endometriosis. So it affects sexual pain in lots of different ways. If you have a pelvic nerve issue, it's going to affect your pelvis no matter what you're doing with it. So, and that burning that you're talking about, no matter what you're doing with your pelvis, usually that burning is going to be present. And lots of different techniques that a pelvic floor or a pelvic PT can help with. Let's see if we have, somebody's calling us angels. That's nice, right? So another question is, what do you do? And this would be great for our panel because it fits with our change in the narrative. But what do you do if you go to doctors in your area and they say, suck it up, it's normal? What's a good, you don't have to have a response to the doctor, but what's a good response to tell yourself?
It's not me. It's not, don't blame yourself. I would probably nod and walk out, but again, don't take it personally. It's something, it's their thoughts. It doesn't really reflect you.
Right. So because I think this will be a big part of our panel, for our couples that are undergoing IVF and fertility, and that medicalization of the pelvis is beginning to affect their relationship, what kind of advice do you have as a PT to that experience?
So I'm not sure I'm following you with the IVF.
So couples that are undergoing treatments and therapy, or that are, it's all focused just around like medical. How do you try to bring the joy back into their bedroom from your profession standpoint?
Yeah, well, so one, it depends on what their comfort is in that bedroom. So I think that's when I would bring in other props and things that would help them as well. And then also just going back a little bit to the joy of each other and the joy of touch. And is that touch safe? Is that touch okay for them? Does the touch feel good? Before we kind of make everything like, you know, X and Y, you know, very linear.
Right. So Anthony Lowe gives in his female athlete, which I think you've taken,
Mm-hmm.
he gives an example of a patient who came in and their central nervous system was just on fire. And he's not a pelvic PT, so he can't do, and you know, he can't address any of the internal stuff. And for the hour, all he did was lightly touch her and to try to get the central nervous system to calm down. And
Yeah.
within 3 sessions, her pain went away.
Right.
So like, we're not saying with endometriosis, we can cure you by petting you,
Right.
but sometimes the body's forgotten what feels really good. Like Niva's saying, like you should be able to explore touch. And sometimes it's backing up from the activity of sex. Also, like what Niva's saying is you should remember why you want to be together.
Yeah.
Yeah. So
And I think the medical terminology, I mean, I'm sure you hear this often. Somebody comes in and they're telling you all the medical terminology, and that's kind of all they're really seeing in their life is those bigger words. And so they're so focused, they have that focus on medical versus, wait, why are we doing this? You know,
Right.
What is the goal actually? Right. And let's go back to our own words of what we want to feel in the bedroom.
And I love that. I love how you know, words matter. And I love how sometimes it takes also like Niva said in the beginning, when you go to a good PT to get that space, to have that, if you have that space to be able to go home and say, hey, I'm supposed to have this space all the time. And it's really important. We have a question about pelvic physical therapy and vulvodynia. I'm going to say the person has said they've tried nerve pain meds. They've tried Botox. We could have a whole hour just on whether or not Sallie likes Botox. I don't know how Niva feels about Botox.
The Valium question was easier.
Right. They tried trigger point injections, creams, and nothing has ever stopped 20 years of burning. And she had excision last year, because that would be my first question. And she's had a pudendal block. So what my genuine with burning, we could back up. We'll have a different webinar on that, but they're looking at the wrong pelvic nerve. Most people don't understand how to break it down to you know, which exact nerve it is, because people always look at it's either pudendal or that's it.
Right.
So again, I don't, you can always DM us and one of us will get back to you. Core Dynamics Physical Therapy is the Facebook page, right?
Yep.
Yeah, and we're of course the Endometriosis Summit. But how do you address when people have vulvodynia and endometriosis?
So you know, sometimes I can address them at the same exact time, I would say, or sometimes it's really breaking up, depending on where they are on their vulvodynia, let's say, because they could have provoked a vestibulodynia, couldn't say that, or an unprovoked. So is the burning occurring all the time, or is the burning really only occurring when there is some sort of touch there? So that is where I do like to use dilators when they're ready, 100% when they're ready, and if they're ready at home, to teach that sensation that's normal. Also because I find that the vulvar pain is more attached to the superficial muscles and then occasionally to the deeper ones as well. I'm not saying no. So I don't always have to go internally to get to those muscles. I can work with somebody on an external aspect,
Right.
and really work also on their pelvic mobility and the joints, the hips, and their spine. So that might be separate to the on top of the endometriosis aspect, but so often I see that actually they're coming in for vulvodynia, let's say, and then getting their history and saying, okay, let's explore what else is going on here.
Right. So I would say my patients that really burn, and they're like, oh, you have vulvodynia. They're like, so many of them have undiagnosed hernias, and don't understand. And even I take consult clients from everywhere. And when I go through their histories with them, a lot, like almost all of my consultation clients have ended up having hernias. And people use the term vulvodynia because they know it. And I
Right.
mean, nurse practitioners, sometimes nurse practitioners in very good surgeons' offices say, oh, you have pain from sex, must be vulvodynia. And I really don't think that half of what's being called vulvodynia is vulvodynia.
Actually, yeah.
It could even be a manifestation of interstitial cystitis, which we haven't talked about a lot.
Sure.
Definitely a pelvic nerve issue. Just because the pudendal nerve's injected doesn't mean you've hit the right nerve.
Right, right.
And
Or the right branch. I
right,
mean,
or the
there's
right
more than
branch.
Alcock's Canal.
Right, more than Alcott's Canal. And then the other thing is I think that sometimes I see a lot of, you're right, I see especially the young set, like that 20-year-old, oh, you have vulvodynia. And it's really endometriosis, and that when it's been left around till the person's still 35, it's really hard.
Yeah.
The other thing, and I'll give a little plug because she is also coming to the Endometriosis Summit, but I love for home to give all of the vulvodynia set, the Your Pace Yoga Vulvodynia download.
Yeah.
It's something that, again, we love empowerment. We love exercise because it's not only good for your heart, but it's great for your gut. And so the vulvodynia one is fantastic for re-strengthening without putting you into spasm.
Mm-hmm.
And it's something you can do at home. And she did a code last year. I don't know if she's going to do a code, but that's Dusty Ann Miller.
Mm-hmm.
And she is coming to the summit for the Endo Summit workshop. But she will also be there the day of the town meeting to lead us in a little bit of fun. I know we have a little bit of fun planned last year. Anyone who likes our website with all the hands on it, that's because Niva makes sure you all don't sit down at the town meeting. She is amazing at that. Definitely makes us all feel alive. And I think that that's the crux of physical therapy, is you have to feel alive and not dependent. And we teach the skills to do that. And you're right, it could be something else. So here's my favorite question of the night. Where can you buy tickets for the Endometriosis Summit? And I didn't make her answer that. So the Endometriosis Summit tickets are on sale, www.theendometriosissummit.com. Endometriosis Summit workshop is sold out. And there's already I think there's already an 87-person wait list. I'm not sure the wait list is going to make it.
That's day one.
That's day one. Day one was a new addition this year, and it's a smaller, intimate setting. Day two is our fantastic town meeting where the sex and relationship panel will be, and we basically will recreate this, but in a way in which you're running around the room to state your opinion. I know that sounds crazy, but we're going to make it happen. We did not want to keep you in your seats because you all have rectovaginal endometriosis just like me, and sitting in that chair all the time hurts. So we're going to get you moving around. And the hotel we're using is the W Hoboken, and there are plenty of Airbnbs in Hoboken as well. So Angela brings up an interesting thing. Do you see clients over the phone or over the internet?
I personally have not started that. I definitely looked into it over the past year. And just right now I'm understaffed, so I have kind of a long waiting list and dealing with it.
Yeah.
clientele. So I've not gone there yet, but I do a lot of consultation with my own current patients on emails, and I tend to get everything done on emails, which is nice, but phone
Yeah.
calls when needed.
So I see consultative clients over the internet and over the phone, more likely over the phone. They're not technically patients, it's coaching.
Yeah.
But some people can find it tremendously helpful. I know that many of our other PTs that are coming do it. I'm pretty sure, I know Tracy Sure does it. I know Susan Clinton does it.
Yeah, well, Susan is right, coaching.
Yeah, I don't know if Amanda. So we have at the Endometriosis Summit, we have I think 11 PTs on faculty, which is pretty impressive. Yeah. So and that's why we chose this year to do a physical therapy meetup in one of the evenings. So yeah. All right. So we're out of questions. What is there anything left that you would like to add about sex and relationships and endometriosis?
Yeah, I mean, so this is definitely a multidisciplinary approach. And again, I'm sure you get this a lot from patients, like, wow, you know, you're like my therapist, you're like my psychotherapist. I am not personally a sex counselor or have gone through any of it. I think just the experience and the experience from the patients, but outside of the PT, I hope people are not embarrassed to go speak to a clinical therapist when it's needed, and with their partners or without their partners, whatever it is. And you know, you mentioned something that Tracy had put up the other day about the chart about the sex, the two sides of the sex thing. And yeah, I mean, there's more than sex right now. Then you don't have to start with penetrative sex, right? Not right away, if that's a danger aspect to you, and really learning how to be a couple, which is really not in our scope to go on and say that. But I love it when partners can come, because I think they actually can see what the patient is really going through. I think, you know, for those that have doubts of how much pain patients may go through, they now see, not that they're going through pain in the PT, but they're hearing a little bit more. And then I think they're hearing from the professionals some of our stories, and they're like, wow. But I think it helps both, you know, set it both sides.
So our sex and relationships panel at the town meeting for the Endometriosis Summit will include Dr. Christine Hyde, and she is a sex therapist working in New Jersey, who's also an ASECT. And you can PM or DM if you want to learn more about that. I think that's tremendously helpful. And I want to add, because I have endometriosis and I'm not a couple. And so sometimes, like, going through therapy, you know,
I like that your voice got quieter.
My parents are in the next room. But sometimes it's perfectly acceptable, like, that your goals are not to have sex with a husband or wife. It's totally acceptable that you just want to feel enjoyment. And we have to design goals as therapists to help you get there. And if that means, you know, there are people who are single that go through sex counseling with a counselor, that sees somebody who has the ASEC, to see a physical therapist. You should never think just because you're not in a relationship that you aren't worthy of pleasure, or that it is a right. In every other country, it's listed as an ADL, an activity of daily living, but of course in the US it isn't. We also will be joined by Dr. Gittens, who will talk to us about hormonal management and things that go into painful sex. So let's make that clear, not hormonal management of endometriosis, but hormonal management of the vaginal microbiome and the skin dermatology. And then Dr. Ahmed will be on that panel. She's a pelvic physiatrist, and she talks about rehabilitation medicine in the pelvis. She'll probably talk a lot about the central nervous system. And then I also think we'll have Dr. Shaw, who's a vulvodynia specialist, because we thought that she fit there, that it's really worth, if we're running around the room talking about our opinions on sex, why not throw in somebody else to make them do that?
Yeah.
And
stuff about what you're saying about, you know, being yourself and making, being comfortable with your own sexuality. That goes back to what I was saying earlier, even about the positions. Like, you have to learn. It's much easier for you to know your own body. And then if you do end up coupling up and deciding that's a pathway for you, you now have your knowledge of what feels good to you and what doesn't feel good. And I think a partner actually very much appreciates, like, wow, you have that, empowerment to your own self.
Right. And I think your body changes as you go through surgery. Some people go through surgery and the rectovaginal endometriosis is removed and voila, it's all fixed. More often or not, they've experienced a long-standing delay of diagnosis, and they have like other things that go on. And if you don't understand how your own body works, it's sometimes hard to bring somebody else into it. And the other thing is I address it with the doctor by being like as blunt as possible. I was down here and seeing a doctor, and I have a complication from last year's surgery, and the doctor, it was a new doctor. It's somebody who's specialized down here, who wasn't used to the Sallie Sarrel show yet. And he turned deep red when I very explicitly explained why I didn't want to lose sensation to a specific area of my body, because I've already lost sensation from pelvic nerve damage. And I thought he was going to pass out. So like, that was the key. That was the key, that maybe this is not a practitioner for me. And so for you, if you're as blunt as possible, because and the practitioner can't handle it, that's a warning sign also, that it doesn't mean
not to go say it.
Right. I mean, from the, it depends where if you're, saying to the doctor, I burn here, and they're like, oh no, that's for women have to talk about that with women. Or I once said to a doctor, I don't want to lose the uterus's role in orgasm, and I don't want to have a hysterectomy for that reason. And so this like supposedly world famous gynecology got up and walked out. He closed the office door. No one should hear the word orgasm. And I think
in a gynecology office.
Right, in a gynecology office where they're taking uterus. And yes, the uterus for many is involved in orgasm. So like, you got to lay it on the table if you're having treatment. And then you also have to realize that in itself may change the way sex is. So we're out of questions. I'm going to ask you, we end all our Facebook Lives by asking you to tell everybody what your 2 things you're excited to see at the Endometriosis Summit.
To see, well, I can't wait for the first day, because it's, I was there last year, but this is new. And to hear some of the newer faculty, some I've never met, some are colleagues again. The hands up part last year, that like emotionally, when I look at the website, I am like so touched. So I'm waiting to see. I have to work on it, but this one is dedicated definitely to the ladies this time. Well, again, always to the ladies, but really dedicated to the ladies.
Don't forget, we're inclusive. We have to be totally inclusive. So,
yes, to everybody.
Right. So I think for me, what am I looking? I'm looking forward to Nancy Peterson of Nancy's Nook for Endometriosis is our keynote, and she's not going to give a boring speech. She's going to do a fireside chat where there's lots of freedom for her to speak off the cuff. And I see it on Facebook, so I can only imagine what it's like for her to be totally unscripted in a big crowded environment. So I'm really excited for that. Also, I've only met her once, so I'm like excited to spend some more time with her. And really, I loved dancing with you last year. And I can't wait to come back and to experience that again, and to experience one thing that I wanted when I created the Endometriosis Summit was to unify patients and practitioners so that we get a lot of PTs there, because we want to show them, that we play such a role in endometriosis. But it was to show that people with endometriosis have a say in their lives and a say in moving them forward. And I just love, like, whenever you ignite the crowd like that. It sort of teaches everybody we're going to come together as a community and move on. We're not going to sit in a room. I'm definitely not the website where you see everybody crying. We're going to celebrate who we are, and we're going to use our voices to move endometriosis forward.
Yeah,
So,
and honor all those people in that room that, you know, spoke last year was amazing.
yeah, and honor, I love the crowd that comes. And I think the person that learns the most is probably the person that doesn't say anything. And they, in some ways, they're the voice that we do this for. So I'm really excited. We are selling quickly. We expect a sellout. So if you're buying tickets to the town meeting, I would go and buy tickets to the town meeting. And again, the workshop is sold out. I know a lot of people want me to expand the room, but the room that we're using at the W is all glass and it overlooks New York Harbor and Hoboken. It's a brand new room in the W, and I'm not expanding because we get a whole
different room.
side. Yeah, we get a whole side to do yoga and meditation in.
Oh, wow.
I have to do yoga and meditation. So yeah. So I will see everybody there. Niva's blog discusses a lot of the things that we discussed tonight, including helpful tips for how you should move forward with sex and with relationships. And then Niva had this fantastic idea to do an interview with the patient. So part 2 will be running later in the week. It's kind of sex and relationship week. So check out that. And then next week, we will be here with Dr. Joe Rakuya and Dr. Eugenio Colon. Eugenio Colon is an endometriosis excision specialist out of St. Louis, and he is new Endometriosis Summit faculty. Dr. Rakuya is running a study on how, just how much endometriosis falls outside of the reproductive organs. And our topic for next week will be extragenital, so non-reproductive organ endometriosis. So ureter, kidney, lung, belly button, nerve. Eugenio Colon is in St. Louis, so they do a lot of pelvic nerve work there. And it should be really fun. And usually when we have the doctors on, we do get, usually Dr. Vidali pops on. He just thought the PT should have at it tonight. So, you know, maybe we were more honest. You know, maybe we didn't need Dr. Vidali for the sex pillow talk, you know?
Right. Next time.
Yeah, and so there are tickets available, and there's also sponsorship available. And we added this year, it'll be so cool. Everybody will wear their shirts for your dance. So you can buy an Endometriosis Summit t-shirt before the event. And then we're going to do a group photo during lunch. So that'll also be very exciting.
Awesome.
All right. I will see everybody back here. Let's thank Niva for being here, for taking time out of her busy schedule and away from her kids. Happy New Year.
Happy New Year to everybody. And thank you for having me, Sally. I really, really enjoyed it.
All right. And hopefully we'll have you back. We're going to try to run these maybe not every week through the year, but at least once a month. So maybe we'll come back together.
Yeah.
All right. Take care.
Bye.
Bye. Bye, everybody.